Hello, I'm Roseanne. According to World Health Organization, cardiovascular diseases is the leading cause of death globally, taking an estimated 17.9 million lives each year. Now, why am I mentioning this? Well, in my last video, I said that I'd analyze an article that explains race disparities in healthcare. However, I thought the subject was too broad and that it would be interesting to research something more specific. And then I found out that both Black men and women have a much higher risk of heart failure compared to their white counterparts. Why is that? So today I will be analyzing the article, Race, Discrimination, and Cardiovascular Disease by La Princess C. Brewer and Lisa A. Cooper. Timestamps and source material will be in the description down below. The health wellness idea presented in this article is the major health concern regarding cardiovascular disease and race disparities. There is plenty of research that links race-associated disparities and those who are affected by and die from cardiovascular disease. Among all ethnic groups in the U.S., Black Americans have the highest mortality rate for coronary heart disease, as well as a higher prevalence of cardiovascular disease risk factors. Results from various studies have made investigators more interested to study beyond traditional risk factors for cardiovascular disease towards psychosocial risk factors in hope that we can better understand and offer solutions to these issues. As a result, this article analysis aims to understand how chronic exposure to racial or ethnic discrimination contributes to both observed cardiovascular disease and cardiovascular care disparities. Racial stressors can be considered a type of environmental stressor that reaches a societal and individual level. There are detrimental effects that life experiences have had on the health of historically marginalized groups, and thus this leads to the findings that link the perception of racism to the link of cardiovascular health. In addition, race-related stressors can increase the probability to engage in negative health behaviors, and as a consequence, there is greater impact on the management of multiple CVD risk factors by minority populations. Brewer and Cooper studies of a large sample of urban primary care patients have found, as they put it, that expressing race consciousness was associated with higher diastolic blood pressure and may be associated with higher systolic blood pressure among Black, but not white patients with hypertension. Furthermore, colleagues found that Black Americans have higher levels of race-related vigilance from anticipating or repeatedly experiencing racial discrimination have had a higher likelihood of hypertension than white Americans. Investigators Jackson Hart study evaluated the amount of time discrimination occurrences, the frequency, attribution, and burden in relationship to hypertension prevalence among Black Americans. Race discriminatory attitudes and behaviors held by healthcare professionals could contribute to the diagnosis and management of CVD that are less than optimal among patients from minority groups, specifically Black Americans. Deep-rooted racism has led to inequalities to access to and quality of healthcare, as well as disparities between treatment of colored people and white people. People belonging to minority groups will continue to experience inequalities in heart disease treatments, including effective treatment therapies for acute coronary syndromes, cardiac catheterization, percutaneous coronary interventions, and surgical revascularization. Data shows that not only are Black Americans less likely to be admitted to medical facilities with revascularization capabilities, but they also have a lower odds of achieving a door-to-balloon time of fewer than 90 minutes and see longer revascularization times than their white counterparts. Many cardiac clinicians, including cardiologists and cardiac surgeons, are unaware of the existence of racial/ethnic disparities in cardiac care, with only about a third agreeing that racial/ethnic disparities exist in cardiac care in the U.S. Stereotyping or bias in physician decisions seems to be practiced when there is a substantial variation by race and gender, referral of standardized patients with similar presentations of cardiac symptoms for cardiac catheterization. According to one study, patients that experience discrimination such as stereotyping and prejudice in their healthcare setting are less likely to attend healthcare services which has a negative impact on patient satisfaction. The patient-clinician relationship could lead to the distrust in the medical infrastructure if they perceive they are being discriminated against, whether it is from subtle passivity or apathy, or to a more overt annoyance of touch, as seen from surveyed Black patients with hypertension. One would argue that patient refusal or rejection of medical advice or services drives cardiovascular health disparities, but that would be incorrect because patient refusal accounts for only a small portion of observed racial variations. It is important to address the potential problems in patient-physician communication due to the findings that Black patients often receive less patient-centered care, such as less psychosocial and rapid building or shorter medical visits than white patients with similar CVD risk factor profiles. Not only may Black patients receive inadequate medical counseling, but they may also have inaccurate perceptions about the seriousness of medical conditions and the necessity of chronic therapy. Research that's aimed to understand the effects that experiencing discrimination based on race or ethnicity has on CVD risk could, as Brewer and Cooper put it, have a significant impact on future clinical and public health practice. Physicians should be educated on the relations between race or ethnicity and the healthcare disparities in cardiovascular care, as well as the influences that psychological and environmental stressors have on cardiovascular health. In addition, if more medical education programs helped physicians develop skills with the trust of patients from minority groups and engage with such communities, they'd be able to come up with innovative strategies that could overcome health disparities. We've gotten to the end of this video. What have we analyzed? Well, we have brought up the major health concern regarding cardiovascular disease and racism. We have seen how race could play a part in as being a stressor, and how race influences the access and quality of care. We've also seen how race could play a part in the patient-clinician relationship and the adherence to medical therapy. Thanks for watching until the end, and I'd like to repeat that once again, the author and link to this article will be in the description down below. I highly recommend you checking it out if you'd like more information on this topic, or if you're interested in seeing anything I left out. Next time, I'm thinking of analyzing an article that talks about how internalized shame has an effect on the mental health of the members of the LGBTQ+ community. I hope that no one from my church finds that video. Well, anyways, make sure you subscribe and click the notifications button to be notified of any future videos like these. I hope to see you all again soon. Goodbye.